afternoon, everyone. My name is Camila and this summer I've had the privilege of working in Dr. Desiree LeBeau's lab and her team in the Division of Infectious Diseases, where we've been investigating the impact of mosquito-borne viruses, specifically in the highlands region of Kenya. So to begin, I want to give you guys a quick but important fact. Nearly 80% of the world's population is at risk of contracting mosquito-borne viruses. And this means that every year millions of people are infected with these arboviruses, and in some cases it can lead to life-altering complications, long hospital stays, and in some extreme cases even death. And yet in many parts of the world, we still don't know exactly where and how these viruses are circulating. That's where the focus of my research project comes in. We focused on viruses like dengue, chikungunya, Rift Valley fever, and nyang, all of which cause widespread outbreaks of febrile illness, primarily in tropical regions. And so these viruses cause symptoms ranging from mild fever to more serious complications of hemorrhagic fever. And in the Kenyan highlands, there has been no prior surveillance and outbreaks are not documented. So while people are getting infected with these fevers, this lack of information makes it harder to respond effectively and thus prevent future disease spread. So our study asks, are mosquito-borne flaviviruses a significant cause of febrile illness in the highlands region of Kenya? Which viruses are currently circulating in this region? And how can this knowledge then better support future disease surveillance, clinical treatment, and control in this region? So in order to investigate these questions, our lab analyzed 150 plasma samples from febrile individuals in Nandi County, which is a part in the highlands region of Kenya. And our lab worked in close collaboration with Kenyan physicians in order to clearly communicate the goals of this study with the individuals who participated in the study. And our research also built on the findings of a previous project done by one of our lab colleagues, Dr. Ezra, who tested for IgG antibodies against alphavirus, virus, and flaviviruses, all of which are families under the arbovirus species. And she tested via indirect in-house ELISA. And so in my project specifically, we expanded on the findings of the 2.7% flavivirus seroprevalence. So our research had 3 key steps, and the first step was the RNA extraction, where we isolated the viral RNA from the plasma samples, and then we used that RNA to convert to complementary DNA through the process of reverse transcription. And then with the complementary DNA, we did the real-time qualitative PCR, where we amplified part of the viral genome in order to allow us to identify any active infections, and then from that we can determine circulating viruses. And for this RT-qPCR, we specifically use the pan-flavi protocol, which has primers that can broadly detect any flavivirus, including dengue and Zika. And so this is what we found. All 150 samples resulted negative for flavivirus, which means that these findings suggest that flaviviruses were not detected in these first 150 samples, but it cannot be completely ruled out as a cause of febrile illness due to the limitations that we'll later explore. But we concluded that these samples were all negative because their melting peaks at around 75 degrees Celsius match the melting peak of the negative control seen here in blue, which is also at around 75 degrees Celsius. And then there's a clear difference with the positive control in red that has a melting peak at around 84 degrees Celsius. And then over here in the amplification curves, we can see that the clear exponential growth is from the positive control, while the samples tested and the negative control are all not really, they haven't really amplified. And so the limitations that this study had were that the qPCR data showed some non-specific amplification, but that can be differentiated between looking at the positive and negative controls. And then we also had a limited sample size, which may not represent the full regional circulation. And then also RNA degradation, it could affect the detection sensitivity. And probably the most important limitation to keep in mind is that the samples that were extracted may have been outside the viremic period of infection, which means that the which means that the patients do not have virus circulating in their bloodstream. Therefore, the PCR would not be able to amplify that part of the viral genome. And from this research, I learned so much more than just lab skills. I learned that there's a lot of value in the preparation and the teamwork and in the trial and error that goes into the research and scientific process as a whole. And then one thing that really stood out to me also was learning about the One Health approach, which is really centered on the interconnectivity and interdependence of animal health, human health, and environmental health in healthcare and medicine. Which is really important to keep in mind, especially now as our climate is changing and as animal habitats are expanding or changing, and then that can impact human health. And then also, I began to understand the need to know disease prevalence in order to help better inform care and prevention in different communities. And so, from here, our lab hopes to continue screening samples for chikungunya, Rift Valley fever, and anemia, as well as expand the sample collection to include more febrile individuals and regions. And then there's also this need to understand more about febrile illness in the context of emerging infections. So more studies like this could help expand on that. And then I hope to carry this experience forward as I hope to pursue a career in medicine and study global health in college. And I would like to thank my family for their love and support, my mentors, and especially the LeBeau Lab for sharing their passion and knowledge of infectious diseases with me. Thank you.
The difference between positive and negative, how many base pairs is it? Is it point or is it more than one? And do these differences account for heterogeneity between populations?
For what?
So between positive and negative, the controls, what is the difference?
So our negative control was a negative human sample that does not have any virus in it, and then our positive control was like lab-grown dengue 2 virus.
And how many base pairs is it? Like, what is the base pair difference when you do the melt? Do you know that?
Unfortunately, I do not have the information.
It's just very interesting that there was none that came out. So I was wondering, and then why we see that bit of amplification. I was wondering if it's to do with heterogeneity between populations.
Well, the non-specific amplification may just have been that the things were like attaching to something and showing that little bit of like growth, but we concluded that it wasn't anything significant based on like multiple trial runs, and yeah.
Thank you.
Yes.
Into choosing a specific region?
Yeah, so we chose the Highlands region because previously it was thought that at altitudes at above 1,500 feet, there is not really any mosquito-borne virus circulation. So the Kenyan Highlands, specifically Nandi County, is sitting at an elevation of 2,000 feet, which is over the 1,500 feet mark. So the fact that there has been people that had antibodies to these viruses can suggest that the mosquitoes are expanding their habitats to more to cooler regions, but because of climate change, these regions can now be considered warmer climates for the mosquitoes to like be in. Yeah. Yes?
How exactly did the physicians collect patient samples?
So people with fevers went to local health centers in Nandi County, and physicians would just like extract the blood, and then we centrifuged it to get the plasma, and then from the plasma we extracted the RNA.
Me?
Yeah.
I found it very interesting because if you're doing this for societal health, if you've got a lot of influenza infection, then you need to treat the patients for influenza. If you've got a lot of, say, dengue or mosquito-borne diseases, then you have to treat for that as well. Or your mosquito management has to change. Right? We don't have infinite money, we don't have infinite resources. So knowing what your patients are coming in with, I think is very interesting that it's not just knowing what the population has, but how that might inform your colleagues on how to address outbreaks. That concludes our talks, I think. Thank you.
Thank you.